Perfect. Good evening, everyone, and welcome to the third part of our webinar series. It's not the last of the webinar series for the Healthcare Workers Care Network. Please do stay in touch and we'll keep you posted of the next webinar. But in our introductory webinar series looking at the mental health of healthcare workers, we've come to a very important session tonight where we're covering grief, loss, and moral injury. And it's a perfect time to start having these conversations. It's a very difficult and hard topic to discuss, but really important. And we have a great lineup of speakers who are going to tackle this really impactfully and sensitively. We appreciate everyone for joining us tonight all over the country, as well as from all over the world. It's amazing to see people from Australia, Mauritius, all joining us. We really do appreciate everyone's time on this Tuesday evening. I can see people are flooding in. And just as a reminder to please put your audio on mute. You can also put your video off. It just helps you to make sure that you get the best network and coverage for the whole webinar series tonight. Tonight's program starts now. We're hoping to finish by 8:20. Another reminder that this session will be recorded. The presentation slides will be made available and they'll be up on the Healthcare Workers Care Network website by tomorrow that you can download and access. We'll also be sharing a link for your online registration for CPD points. So you'll be able to apply for that after the session, or even if you're looking for a certificate of attendance, we will share that link in the chat box. I encourage you to post your questions in the chat box. They're incredibly useful for us and our team. We're able to answer them at the end of the session, but more importantly, we use that information to develop content and even some ideas for future webinars. So please do stay in touch with us on chat and post any questions that you have. Without further ado, we're going to start off our first session. And I think for the lineup that we have tonight, I think a perfect quote to really start from Martin Luther King Jr. The ultimate measure of a man is not where he stands in moments of comfort and convenience, but where he stands in times of challenge and controversy. And I think when we're touching the topic of grief, loss, and moral injury, it's a very heavy topic, but I'm hoping that after the session, you gain some more insight, information, and even feel more prepared to take on tomorrow. So for our first speaker tonight, we're going to be introducing clinical psychologist Batetsi Matengi, who is a clinical psychologist as well as part of the Gauteng Healthcare Workers Care team for the regional team, is registered with the HWCN and the Board of Healthcare Funders. She has a special interest regarding working with individuals as well as children and couples, dealing with all kinds of childhood trauma, life challenges, interpersonal and relationship difficulties, clinical disorders such as depression, anxiety, and bipolar, and has been very involved in training and workshops and talks on mental health to various organizations. So without further ado, Tetsi, I'm just going to ask you to unmute and we'll spotlight you, and you can cover the topic of loss and grief this evening. I'm just going to...
I've unmuted myself, so you should be able to hear me now.
Perfect.
Good, good, great. Good evening, everyone. And thank you so much, Cassie, for that lovely introduction. So as Cassie hasn't introduced me, my name is Batetsi, and I will be speaking on the topic of loss and grief during COVID-19. I'm just going to share my screen for the presentation, just so everyone can see. Please just let me know on your side if that's what if you're able to see that. Okay. Share screen. Is it shared?
Not yet.
Okay. Is it shared now?
Yes, it's loading. Perfect.
Okay. All right, great. Okay. So as Cassie has said, I'll speak about loss and grief during coronavirus, because as we all know, we have all been affected by the recent coronavirus outbreak, whether that's by contracting the virus, knowing someone who had the virus, losing a loved one, or experiencing a general sense of loss or a disruption to our daily lives.
Sorry to interrupt there, but Jessie, can I just ask you to do the slideshow so it takes up the whole screen so it's easier to read?
Is it not on slideshow? Okay. Is it on slideshow now? Great.
Perfect. Thank you.
And I can just sort of click, right? Okay. All right. And in terms of the impact of the virus, there's been multiple losses occurring in this virus, and they can all be detrimental to mental and physical health. This is because the losses occur within a constricted time period, which can also result in bereavement overload. In such unpredictable and uncertain times, loss manifests itself in a variety of ways, and grief appears to be a primary outcome of COVID-19. Individuals and families across the globe face several losses: loss of income, loss of financial security, loss of dignity, status, possessions, independence, healthcare, and a sense of future. These losses are especially devastating in the South African context, given the high unemployment rates. And the coronavirus also reflected a very painful past that we're all aware of, which is the context of a racial trauma and poverty in our society. Measures such as the lockdown also resulted in a loss of freedom, and this can lead to secondary losses such as losses of relationships, recreation, and social support. Social distancing measures minimize emotional and physical intimacy, and this can result in the dissolution of intimate relationships involving partners, family, and friends. For example, it was very hard to be in the presence of family members who are receiving treatments like chemotherapy because they had to face intense isolation practices. As well, there were limited or no visits to elderly parents who are also deemed at risk during a time like this. Individuals are also faced with making tough sacrifices, anything from a special event to a disruption in our day-to-day routine. Death and grief during COVID-19. Death-related loss during COVID-19 pandemic can have lasting effects and turn into complicated or prolonged grief when we consider risk factors such as multiple losses that people have experienced during this time, the mode of death, personality traits of the person, the situation in which one finds oneself during and after the loss, as well as a lack of support. The grieving process reflects a confluence of responses, including affective, cognitive, behavioral, physical, and spiritual. And the types of grief that people experience or have experienced during COVID-19 include the following. Many families may experience what we call anticipatory grief, which is when they know that their loved one is suffering and that they may be missing out on the final moment of their life. The absence of rituals, such as funerals, can often also result in disenfranchised grief because lacking social or cultural recognition impairs support resources that assist in the grieving process. Individuals may experience ambiguous loss amid and post the pandemic. For example, patients that are under quarantine may experience physical separation with family, although they stay emotionally and psychologically connected. Some individuals with COVID-19 experience stigmatized loss as they are blamed for contraction and transmission of the virus. So how do you survive the loss and grief of COVID-19? A willingness to experience grief without resistance is important, because this prevents a suppression of emotions which can otherwise result in depression. Allow yourself and others to express emotions relating to loss and grief in your unique ways. Validate the extent of the loss and speak more openly, and do not hide behind work, social media, or binge watching television. Listen to other members in the household and create opportunities to talk about the effect of COVID-19 on everyone. Create virtual wake ceremonies or prayer groups via WhatsApp or other digital communication media. Set up a mourning corner if you can in the house, with a picture of the deceased, where members of the household can have time alone to grieve. Create a memory corner in the house or a garden, and if you like, you may journal or write, and continue to look for messages of hope, offering reassurance that feelings associated with loss and grief are normal responses to abnormal or unusual circumstances like this recent crisis. In conclusion, while loss, grief, pain, and suffering can feel unbearable, you do not have to build a house and move in. It is only part of the human experience, not the full story. There's also incredible love, grace, and beauty around us. Hope is needed to sustain life during these dark times, and we possess resilience, healing, a capacity to develop compassion because of our own suffering, as well as the ability to gain perspective over time. So I'll just end off with a little quote here by a psychoanalyst whose name is Hannah Siegel, just as an offerance of hope. She says, "It is when the world within us is destroyed, when it is dead and loveless, when our loved ones are in fragments and we ourselves in helpless despair. It is then that we must create our world anew, reassemble the pieces, infuse life into dead fragments, recreate life. The important thing is to keep a little fire burning, however small, however hidden. I find this extraordinarily helpful. We live in a mad world, but for those of us who believe in some human values, it is terribly important that we just keep this little fire burning." Thank you. I will now hand over to my colleague, Joanna, who will speak about the second half of the presentation.
Thank you so much for that really great introduction and just getting us even just thinking about this. I'm now going to introduce Dr. Joanna Taylor. If I can just ask for her to come forward. But Tetsi, you can stop your share from your side so that Joanna can share from hers. Just a bit of a brief bio about Dr. Joanna Taylor. She's a specialist psychiatrist currently in private practice in Saxonwold, Johannesburg, and she has a particular interest in the mental health of trainee healthcare workers and in bioethics. So just to hand over, good evening, Dr. Taylor.
Hi, Cassie, and hi, everyone. Thanks for being with us this evening. So we're talking now about moral injury. The language of moral distress and moral injury have gained ground in the healthcare context to articulate something more specific than the idea of burnout. And these concepts can enrich our thinking about the psychological effects of extreme working conditions and the most helpful types of support. The terminologies emerged from nursing literature and been adapted from military trauma research and include the useful concepts of moral dilemmas, moral distress, and moral injury. Sorry, I think my screen share is not on the, my buttons are not working, so I'm just gonna go out. Sorry about this. Sorry. Sorry about this. I have to figure out how to share this so that the...
Do you want me to share, Joanna? Would that be easier?
Is it working now?
I think internet is sharing.
Sorry.
I think internet is sharing for you. Is that okay?
Yeah, that's fine. Thank you. Sorry about that. Okay, so we're talking about these three ideas: moral dilemmas, moral distress, and moral injury. Okay, we can move on to the next slide. So why are we talking about morals and not ethics? Morality is where our sense of who we are intersects overtly with our sense of who we are in relation to others and to broader society. Ethics can be confined more to a professional role. Moral positions are broader. They bring all of this, these news headlines that we see here, into play. And healthcare workers are not acting in isolation from the world around them. One of the strong themes of the research on what predisposes healthcare workers to mental health effects of working in this pandemic is that they are much more vulnerable to mental health complications when they have had colleagues directly affected by the virus, particularly if fatally so. It's interesting talking about this tonight as we enter level 2. There's been so much pressure to reopen and restart the economy with such crucial lubricants as alcohol. And I think that many healthcare workers would agree, as susceptible to economic pressure as anyone. And yet they're also standing tonight in casualties that have been cushioned by curfews and alcohol bans. And those casualties are going to look very different later this evening to how they've looked in the past few weeks. So now we're going to look at some definitions. So moral dilemmas are expected, difficult parts of clinical practice. There's often no comfortable answer to the problem posed, and training must offer best practice solutions that include ethics consultations, team discussions, and supervision. And we think that opportunities to grapple with such dilemmas with appropriate support and guidance make for clinicians capable of crafting sophisticated and compassionate solutions to complex problems. We can all imagine a recent thorny problem that caused us to seek advice. This is routine professional practice. It makes for interesting, rich, and challenging work. And I don't think that any healthcare worker would want such complexity removed from their experience. Next slide. Moral distress occurs when an individual knows the right thing to do, but institutional or other constraints make it difficult to do what is right. And each episode of moral distress is either resolved with sufficient processing or leaves moral residue. Moral residue is constituted by the unresolved emotional and psychological conflicts that make subsequent incidents less tolerable. Moral distress in the context of this pandemic places us in the zone we have been describing elsewhere in earlier webinars of a normal response to an abnormal situation, where serious adverse mental health outcomes are not inevitable, and therefore it's worth optimizing preventative and supportive measures. So this little library nook I've put here because this article on moral injury by Jonathan Shea is really worth a read. Jonathan Shea is the person who coined the term moral injury. And if you're interested in how moral injury relates to trauma and to PTSD, his work is really worth reading. So next slide. Moral injury, a term initially brought into mental health literature by psychiatrist Jonathan Shea in the 1990s, is more recently defined by Litz et al. As resulting from perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs and expectations. In healthcare, these beliefs and expectations include the oaths individual healthcare workers took to provide the best care possible for patients and to make a patient's needs the first priority. And these oaths include undertakings to help people and to do no harm. And while more recent use of the term in medicine has been related to the pressure on clinicians in the context of the modern healthcare system, the current pandemic seems to bring together some of the older trauma-based roots of the term used to develop understanding of symptoms in Vietnam veterans and the more practitioner-related burnout-based meanings. And the current context offers a confluence of extraordinary occupational demands alongside dealing with loss and grief on a large scale. So South African healthcare workers are no strangers to tight rationing of resources, nor to encountering brutal trauma in the course of their daily work. And we're interested in whether these cumulative experiences make our healthcare workers more or less vulnerable to the unique stresses of the COVID-19 pandemic. And we're going to talk a bit more about this a bit later. I've put this slide here not to sensationalize this, but to remind us of the actual context for our healthcare workers. The loss of Petronella Benjamin in her 40th year of service was one of the first healthcare worker deaths to be made public. She contracted the virus at work at age 62. And she died the day before she was due to retire. A statement from Health Minister Mkhize on the 13th of this month tallied our COVID healthcare worker deaths at the moment as at 240, 37 from the private sector and 203 from the public sector. Next slide. So this was written by a friend and medical school classmate of mine now working in the Eastern Cape and posted last week. I've asked her permission to post it, and I put it here not only to remind us of the immeasurable loss of Prof. Pepeta, but because her words tell us all we need to know about how such a loss affects his colleagues. Much has been written this past week about who he was as a doctor, a leader, a researcher, and a father. These words give us a sense of the context of this loss for those left at the front lines, and the despair and anger that come through speak to the heart of the moral distress. And she wrote, "I can't deal tonight. This is just too much. I counted 10 healthcare workers dead in my province just this week. There isn't time to attend Zoom and drive-by funerals. How do we rebuild this service? Prof. Pepeta is irreplaceable. You can't magic pediatric cardiologists of this ilk overnight. It's an unquantifiable loss to our community. Dean of the new medical school. He wore so many hats. The people who have stolen PPE money and not made adequate protection available to us timelessly are really the immoral scum of the earth. The medical service cannot withstand this kind of loss." This is a quote from Rolling Stone magazine last week by an anthropologist called Wade Davis. "The measure of wealth in a civilized nation is not the currency accumulated by the lucky few, but rather the strength and resonance of social relations and the bonds of reciprocity that connect all people in common purpose." And I'm emphasizing the social contract because the essence of the idea of moral injury, that this is not something that goes wrong within an individual. This is something that goes wrong between an individual and their society. So if we think about the role of COVID-19, stretched and increasingly managed healthcare systems globally were already a breeding ground for moral distress and injury. But the COVID-19 pandemic magnifies the pressures in a number of ways. End-of-life decisions and care are harder in the absence of family members. There are various levels of risk being undertaken by all frontline workers. There are many day-to-day dilemmas. For example, oncology services that haven't been able to function and know that the prognoses of their patients are worsening day by day. The TB and HIV service underutilization that's on everybody's minds, the neglect of chronic mental health care. PPE shortages that are worsening the risks faced by healthcare workers and making the choices faced between personal and professional obligations quite stark. The losses of colleagues, patients, family members, friends, and increasing caution fatigue on everybody's part. Next slide. So I have quite a bit in here about rationing. And in the preparation phase, it seemed logical that rationing was going to be one of the major sites for moral distress. And in fact, many of our healthcare workers will tell you that being forced to think so carefully about our use of resources makes for much better medicine, for which we are known throughout the world. Rationing of healthcare resources is something that we could place in the category of a moral dilemma, and if well managed, does not have to result in undue residue and injury, although there may well be some distress. South African healthcare workers are very familiar with rationing and know that it can contribute to sound clinical decision-making. But if protocols are unclear, out of date, or non-existent, support is not in place, and systems are overwhelmed, the pressures on individuals to make and convey rationing decisions will lead to moral injury. In March 2020, professional societies and ethicists were swift in providing guidance on such matters as the rationing of ventilators and ICU care, and many South African hospitals quickly endorsed the Critical Care Society of South Africa guidelines of 2019. So those are those guidelines. And there were several guidelines published, and I remember following the publication of each guideline eagerly, looking for answers. But what emerged over the coming months was that most of the painful and taxing dilemmas for healthcare workers presented themselves lower down the decision-making tree, before one might have the benefit of a manual to consult. Who to admit to hospital and when, how to explain to families how you are allocating an oxygen outlet, whether to continue certain essential but not quite urgent services, whether to go to work with mild symptoms and risk infecting others, or stay at home and know that your team was taking strain. The list is long. And many healthcare workers have also struggled with distress and ambivalence about current allocation of resources after years of witnessing a healthcare system stripped bare, with the resulting thousands and thousands of deaths and reduced quality of life each year from preventable causes. So we've covered some of the context. Back to the nature of moral injury. So this is a slightly different definition by Litz, which is the profound psychological distress which results from actions or lack of them, which violate one's moral or ethical code. Can include acts of perpetration, acts of omission, and experiences of betrayal from leaders or trusted others. Next slide. Moral injury is not a mental illness in itself, but experiences of potentially morally injurious events, PMIEs, can lead to negative thoughts about oneself or others, deep feelings of shame, guilt, or disgust, which in turn can contribute to the development of mental health problems, including depression, PTSD, and anxiety. If we have a slightly broader definition, when a moral injury does occur, the range of outcomes are broad and can include feelings of guilt, shame, anger, sadness, anxiety, and disgust, intrapersonal outcomes including lowered self-esteem, high self-criticism, beliefs about being bad, damaged, unworthy, or weak, and self-handicapping behaviors, interpersonal outcomes including loss of faith in people, avoidance of intimacy and lack of trust in authority figures, and then existential and spiritual outcomes, including loss of faith in previous religious beliefs and no longer believing in a just world. And you can see the links here with PTSD, but also the specific emphasis on how this damages one's relationship with oneself, with others, and with one's place in the world. So factors that are known to increase the risk of moral injury include loss of life to someone considered vulnerable, like a child, if leaders are perceived not to take responsibility for the event and are unsupportive of staff, if staff feel unaware or unprepared for emotional or psychological consequences of decisions, if the PMIE occurs concurrently with other traumatic events, like the death of a loved one, and if there is a lack of social support following the PMIE. So you can see how these factors relate firstly to what we've discussed in webinars 1 and 2 in terms of what is protective for healthcare workers. For example, a team environment, psychological preparation, and the harnessing of support networks. And secondly, how the COVID-19 pandemic creates a perfect storm for moral injury. For example, parallel bereavements, working in a broader context of unaccountability, mixed messaging, and corruption. So in terms of implications for support and treatment, preparing psychologically for the impact of PMIEs is helpful. It sounds so feeble in the face of a problem like this, but it is the case that thinking through these events in advance is protective. Seeking informal or peer support early on is protective. The evidence shows strongly, and we know that people working in extreme conditions want to talk to those who share their experiences, and that doing so is one of the most helpful interventions. To an extent, it happens instinctively, but if it can be facilitated, that is important. Confidential professional support must also be available, and help seeking must be encouraged. There must be a culture of encouraging that. And then, importantly, clinicians should be made aware that individuals who develop moral injury-related mental health disorders are often reticent to speak about the guilt or shame, and may instead choose to focus on more classically traumatic elements of their presentation. Therefore, sensitive inquiries about the events are advisable. Next slide, please. So if the shame or guilt is missed, Neil Greenberg tells us that there's a thought that can get planted. If people knew what I was really like, I'm a monster. And if that is missed and it's not addressed, that thought dooms future treatment. And here it's really important to bear in mind the prevailing hero discourse. The danger of the hero discourse about healthcare workers is the huge gap it seems to create between how someone might see themselves if they're experiencing guilt or shame, and how heroic healthcare workers are being portrayed in the media. This perceived gap makes it even harder for people experiencing the effects of moral injury to speak about their subjective experiences. Jonathan Shea's initial work, sorry, I'm still on that slide, on moral injury foregrounded the way in which the syndrome itself obstructs successful treatment. Okay, we can move on. So Shea also held that due to the social nature of the injury, the solutions wouldn't be found in traditional methodologies. And because of the rupture between the individual and the community, he suggested that that was where the reparative work would need to be done. Next slide. So some of the things that he found to be most useful in his work were group work, and this was to be done with peers. He writes about this as the first step in healing the social or communal injury. Multidisciplinary teamwork, he emphasized how important this was in complex injuries of this nature, and advocacy. And in terms of advocacy, he's talking about speaking to leaders of institutions and teams about what is truly preventative and acting on the evidence to prevent this from happening to more people. So back to prevention. What do we know about that? So I'm going to skip through the stuff about ethics committees. We can talk about that at the end if people are specifically interested in that. But I think we've got quite a bit to get through. And we've got some videos that we want to look at. So I'm going to move to that. But this is all on the slides that you'll have if you want to look at it. So we've relied quite a bit on these guidelines, which are also very useful if you want to look at them. So I'm just showing you what they look like, and they're in our references. So now we're going to move on to talking about 3 levels of preventative work that are important, looking at the level of the organization, the level of the team, and the level of the individual. So organizational tasks that are important for prevention are to acknowledge the inherent moral stresses for healthcare workers during the COVID-19 pandemic, to promote a supportive culture within the workplace and arrange access to a range of support services for staff, to recognize the critical role of informal and volunteer service providers, and to ensure sufficient resources to support the health and safety of these providers. And you'll see the thread as we talk about these preventative measures. You'll see how this ties in with everything that we've been saying in the previous webinars about what is preventative in general for the mental health of healthcare workers during this pandemic. Okay. Next slide, please. So the other tasks for team leaders in teams, including rotating staff between high and low stress roles, establishing evidence-based policies to guide ethically difficult decisions such as the allocation of scarce resources, removing difficult ethical decisions from frontline workers, arranging rosters for shift workers to follow the clock with a cycle of morning to afternoon to evening shifts. And then next slide, providing strong leadership and establishing cohesive teams with high morale, being prepared to discuss moral and ethical challenges, helping team members make meaning of moral stresses, modeling positive coping and encouraging self-care and help-seeking as required, celebrating successes, however small they may be, arranging regular check-ins with staff to monitor well-being, and facilitating referral for further support or counselling if required. I'm running through these like these are just easy things to do. But as you know, we've had whole webinars on all of these things and on how to go about doing these things. So what we're going to do next is we're going to watch some short videos. If you've been following our work and the referencing that we use, we rely quite a bit on the work of Professor Neil Greenberg. He's a professor of defense mental health at King's College in London. He's a consultant occupational and forensic psychiatrist who served in the UK Armed Forces for more than 23 years, and he's been deployed as a psychiatrist and researcher to a number of hostile environments. And he's been at the forefront of developing peer-led traumatic stress support packages that are now in use by a variety of organizations. And he's widely published, including more than 200 scientific papers. He's also assisted with the aftermath of disaster events, including September 11th, the 2002 Bali bombings, and the 2005 London bombings. And we've found his writing on these topics really useful. And Antoinette arranged for us to interview him. So we're going to play a little bit of that. So I think one of the things we'd love to hear your take on is what were initially, when you started doing this work with the military population, is what were some of your entry points or your ways of fostering interest in or acceptance of more psychological paradigms in individuals or populations that might not have been used to that way of thinking? I think that's our first question.
So I guess in the military, I served for 23. My initial time was as a junior doctor, so you were dealing with health, across the context, and people were really interested in their health in terms of what it prevented them from doing and what it allowed them to do. So if you were marching, for instance, people were very interested in their feet health. How do you stop blisters? Because that allowed them to do better times and perform better. And so translating that to mental health is just talking about well-being and health by itself isn't particularly attractive either to individual military members or to the unit or the commanders. See, if you translate that and talk about how it's going to help you do your job better and how you're going to perform better and how you're going to deliver a better service, or if you're a commander, how your team is going to perform well so you'll look good because you want your team to perform well, some people are very interested. The sales pitch that I found was useful wasn't one which was necessarily health and well-being and mental health is good focus, although I believe that. It was very much about how do we help you perform your best and how do your teams deliver the best output. And that was something that everybody was interested in and their ears would prick up. So that was kind of my sales pitch. And I think in terms of what's gone on lately, most healthcare professionals are really interested in doing the best for their patients. And I think most healthcare managers want their teams to perform well and they're not to be too many accidents or serious untoward events. And therefore, if you come at it from that angle, it's a much easier sell than coming at it on a mental health angle by itself. If that makes sense.
Neil, following on the leadership or the training to the supervisors during the pandemic itself, what was your feedback from them? Because we've had mixed feedback. So they loved the training, they loved the information we gave them, but some of them said when the pandemic hit in that peak phase, they just forgot everything and there was absolute chaos. And so they were wondering about the usefulness. However, when we went back and spoke to them a little bit more about it, we actually found that they did use the skills. But we were just interested in hearing your views.
I think that's always the case because, we know from our work, because sometimes you have patients, and even with the best skills in the world, you feel you can't help them. Their situation is so tragic that, there is no simple words that we can say to make it better. That it's understandable why they are in that situation. And hopefully we then put in place a management plan and work out how to help people. That's what we do clinically. If you're a supervisor and this person's telling you how tragic the situation they're in, it can be hard to hear that. I think, you can feel disempowered and we know, actually hearing it and listening is going to make a difference. But for the supervisor who doesn't do that normally, they want to fix it. Well, what do I do now? How do I make it better? So I think if we can reassure them that actually merely the act of listening in a positive way is likely to have made a difference, which I think is true. I think the evidence says that. I think that will help. And I suspect that's why a lot of them will say, well, I couldn't make it any better. But that's true. Sometimes you can't. There is no magic switch, is there? Well, I haven't found it anyway.
We've just got another couple of slides. Are we going back to the presentation? So what we're going to talk a little bit about now is the possibility of post-traumatic growth. And you'll notice that this content comes towards the end of the presentation. There is room to talk about strength and resilience and the growth that can come out of this crisis, but only if we first create space for the struggles and the dilemmas and the need for support that may be there. This is no time for toxic positivity. Sorry, I've forgotten about the individual tasks that we have to look at first. So this is the last level of preventative measures. So after looking at the team leader level, we have to look at the individual tasks for prevention. And those are to access psychoeducational material about moral stresses and moral injury, to undertake stress reduction activities such as relaxation therapy, mindfulness or meditation, and most importantly, breathing, because that's something that obviously one can do quite quickly in high stress situations. Attend to self-care through eating well, exercising, maintaining social connections and getting sufficient rest. Supporting each other as colleagues who understand shared experiences. And again, we emphasize peer support. And seeking professional support if you're feeling distressed or troubled by your experiences. Again, it's such a sort of running that list off like that, but we have to bear in mind that these are things we've done whole webinars on. And we do know that they don't just come easily, but they really are worth investing in. So we're going to talk a little bit now about post-traumatic growth, as I mentioned just now. So we can go on to the next slide. So moral emotions can also be positively valenced. And we're going to play another video now. I think before we talk about this slide.
Just wanted to kind of talk about it a bit is the concept of post-traumatic growth. Now, when well in the beginning when I started talking about, there may be also post-traumatic growth, people weren't really interested in hearing about that. Now I think people are looking for hope, they're looking for good stories. I suppose the one question is, in terms of post-traumatic growth, is it a nice to have, or does it normally happen? What are you seeing in the UK?
So I think it's very interesting. So in terms of the scientific literature on it, there's a bit of a debate as to whether you need to be distressed or unwell in order to grow, or whether you can just go through a challenging time and grow as a result. I think my take on it is that you don't have to be unwell in order for it to grow, So what you get a lot is, of course, the public stories is often held by the media, because the media tend to report on the stories they're interested in. And the stories that certainly in the UK, the media are mostly interested in is things that don't work. Sadly, if there's a suicide, or when a staff member breaks down, or there's a death and they're very upset. So those stories are very attractive to the media. And so the person who says, well, actually, that was all really bad, but actually, do you know what? Actually, I survived that and I did a lot better, doesn't tend to get much airtime. When you go around and you speak to staff, I've done that, and I'm sure you have too, is actually, although you do get the highly distressed people, there is a lot of people out there who are saying, I can't believe that I can cope with this, and I can't believe how wonderful it is to work in teams delivering this amazing care, particularly for people who had never worked in sort of intensive care settings before. We speaking to some health scientists who do measurements of people's gait, for orthopedics. That's what they were doing. And when this all started, that all kind of stopped. And they came in to help out in the intensive care, sort of being health assistants. But they were absolutely loving it. And one of them was saying they were going to go back and retrain. And, this was the beginning of something big. But I'm confident that story is unlikely to sort of make it into the media. So I think that what you're getting and what we're seeing a lot at the moment is an awful lot of measurable distress, for sure. But we're also hearing the narrative stories of people who are, thriving in this. And I think the challenge at the moment is for all of us to work out, does that thrivingness, if such a word exists, does that translate into positive action and growth, in 3, 6, 8, 12 months? Or is that just a buzz from doing it now? And the same also is, does the stress which is now, does that translate to illness? Or is that, understandable given the nature of what's going on? And I think the other complicating factor on the distress side, I know we're talking about growth, is that we don't know what a normal level of distress is working in intensive care settings. If you'd have been measuring intensive care 6 months ago or a year ago, there's a lot of people who are going to be seeing really sad stories, aren't there?
Yeah.
And some of those people will have grown, but they'll get used to it. They'll habituate the same way as they will habituate to the stress. And I think it's these people who are coming in new, who we know are more at risk, but they're also more at risk of taking away more from it.
Yeah.
I think we also saw it in South Africa during our HIV epidemic. Especially the three of us, we worked at that time around, it was our internship years and initial training. And we ended up with resilience. Years later, we're able to better cope with this pandemic now because of it. And I think that's one of the fears we have for our junior doctors. They didn't go through that.
Yes.
So in other words, this is their first baptism of fire, so to speak.
Absolutely. And I'm not a great philosophical reader, although I like philosophy, but the Nietzsche's anything that doesn't kill you makes you stronger. That's not mine. And this is something similar to that, for some, not all healthcare professionals. I think the thing that's actually more difficult to understand what the impact will be in terms of growth or illness is in the staff who haven't been able to perform their roles. So like to oncologists who haven't been able to treat, cancers that they know will kill people. It's hard to see how that could lead to growth in the same way that, you could get that from intensive care. That seems a lot more difficult and probably, again, not so well covered in the media.
So, in terms of specifically post-traumatic growth, I suppose what we're trying to do is, obviously the preventative work we're trying to do is trying to promote a post-traumatic growth. But also I just wanted to know, was there any specific interventions per se that would promote post-traumatic growth?
So I think just in the same way that when people become unwell and develop a moral injury or PTSD, there is a period of either avoidance, which happens, or the sort of internal reflection, often full of shame and guilt, so they don't talk about other people. And I think in terms of growth, the same thing goes on is, why should I be so proud? Everyone else has done this too. And I think for both of those two constructs, are you going to be ill or are you going to grow? I think it's the reflective practice intervention of a leader-led, a sensitive leader talking about the realities of what's going on to try and draw out. The fact is, I know you felt you didn't do a good job and that patient died, but what you don't realise is the 37 patients who survived because you did it. And actually that in a team-led, leader-led, team-based, hopefully, open and emotionally safe environment done properly, I think that's the tool to try and encourage growth and to try and decrease the likelihood of illness. Because I think that without that, the more experienced people or other colleagues putting a growth sort of overlay or growth sort of attitude or approach to it, I think it's easy to miss the things that have gone well, and you need them drawn out.
I think that's really useful. We obviously doing ongoing kind of webinar trainings, and I think this is one of the areas where we're going to be going into. Flo, did you want to ask the question about the South Africa specific?
So Tri has just touched on it a bit, but we think that our South African healthcare workers they already have layers of moral distress and injury that date back decades, from working in the apartheid system to dealing with the HIV denialism of the early 2000s. And then in the last decade, we've really been witnessing the crumbling of our healthcare system. The private sector have their own challenges. And we're interested in how you think this might affect their psychological responses to the current pandemic. Our prediction is that it will be protective in some ways for some people, and it may confer vulnerabilities in others. And we'd be very interested in your opinion on that.
I think you're right. There is, I mean, we know it's not a diagnosis, but there's this concept of burnout, isn't there? Which the fact is, after a while, in the military, we had this term. It was called the sick sergeant syndrome. You know, someone who's been around for a long time, they've seen it all, they've done it. They kind of know the lies that the seniors tell to try and get through. And their view is, I'm just going to do what I need to do to get on. You know, I no longer think that I'm going to save people or I'm going to win the battle. I'm just going to do what I need to do. So there's, in some ways, that, as you suggest, Joe, that's protective, isn't it? Because you don't take on too much. But it's also going to be detrimental in terms of both their well-being, but also the quality of the care I think they'd be able to deliver. So I think one of the challenges is, and this is beyond, I think, any of us to directly deal with, is making sure that actually healthcare workers can really believe that someone's got their back. Now, it's great that you've got their back, but it's got to be their supervisor, even if it's not the whole hospital or the healthcare minister. If their supervisor really doesn't give 2 cents about them, I think it's very hard for them to invest a lot of themselves, because otherwise they risk, don't they, psychological burnout is going to happen from that perfect recipe of, you know, lots of responsibility, lots of motivation with no reward. So I agree with you that I think the risk is there, but I think that the solution, if there is one, has to be that at least at supervisor, but hopefully at team or hospital level, that actually the senior management can actually say, I know, acknowledged in the past there was a lack of these sorts of things, but we have to be all in it together and we have to have each other's back. And that obviously would take time for people to believe that that's true, and that's got to be followed by positive actions from the senior management. But I do think you can work at it, because obviously changing the whole healthcare system is a bit difficult. But from the supervisor point of view, if you go back to the supervisors wanting their team to do well, if you can get the supervisors to actually do that, we've got your back, I think you can begin to get more within a team, for sure.
Thanks. Okay, so this is just my one last slide. So as we're talking about there, moral emotions can also be positively valenced and include emotions like pride, gratitude, and compassion. And there was a recent qualitative study of nurses caring for COVID-19 patients that found that while negative emotions were commonly experienced, these were accompanied over time by the emergence of positive factors, including increased affection and gratitude, development of feelings of professional responsibility and competence, and self-reflection and insight. And so it looks like if the preventative and supportive measures are in place and the social contract is not ruptured, it seems that there is room for vocational meaning and purpose to deepen. Thank you.
Thank you so much, Joanna. I just think, oh, we were sharing the wrong one. Thank you so much, Joanna. I really appreciate that feedback, and just seeing everyone's comments, you know, just hearing all of that just makes it so much more real. I'm going to now ask my colleague, Dr. Caroline Lee, to come forward. We're just going to be touching base, and I get to ask her some questions, especially from working on the front lines. So Dr. Caroline Lee, are you there?
Yes, I am.
Fantastic. So I just get to do a bit of a bio, because I've had the honor of working with Dr. Lee over the last nearly 2 years. So Dr. Lee is an anaesthetist in private practice in Johannesburg and the convener of the SASA, which is the Anaesthetist Society Wellness and Anesthesia Support Group, actively raising awareness and supporting doctors with burnout over many years, speaking at many congresses and talks, and now during COVID, lots of webinars, and written many articles on burnout and clinician mental health and well-being. And I think also working on the front line and being very involved in the Healthcare Workers Care Network, in dealing with a lot of it on the front line. So good evening, Dr. Lee. Thank you again for joining us. I just wanted to touch base on a couple of questions. I know you and I could probably talk the rest of the night, but just to touch base, from your experience working on the front lines, you've lost colleagues within your own hospital to COVID. Can you share what that experience was like and how the other healthcare workers managed it and how it impacted the whole team?
Okay, thank you, Cassie, and hello to everyone. To answer that question, I'm going to share a little bit of what it's like working on the front line. So the first contact I had with a COVID-19 patient was when I was asked to go and intubate a patient that was struggling to breathe in COVID ICU. It took more than 10 minutes to don the PPE. We didn't have the hazmat suit, so we had to put on a gown, a plastic apron, head cover, N95 respirator, goggles, face mask, shoe cover, and 2 pairs of gloves. So as I walked into ICU, luckily I was with a colleague at the same time who was a little bit more experienced. He had worked in the ICU before me. So that was my first time walking there. There was a man sitting up in the bed with a huge face mask that I think you know as NIV mask. So it covers his whole face. You can only see a very swollen eyes from having the mask on. And he was struggling to breathe. You can see that he couldn't even put more than 2 words together. He had to say 1 word at a time. And because he was in that full face mask, there was a lot of beeping sounds, there was breathing sounds, there was oxygen flow sounds. I could barely hear what he was saying. So I walked up to him, being very scared myself, being in COVID ICU for the first time, sweating all over the place and with my goggles misting up because I was so, I think anybody that's had worked in COVID knows that there's no time that your goggles not misted up. You can barely see. And I see this man struggling. I went up to him and I said, hello. I introduced myself and I wanted to talk to him, but I can see he couldn't hear me through the mask, through the face shield, through the N95. So I had to shout my words out to him. Well, I can't hear what he said and he can't hear what I said. So we basically shouting at each other and not hearing each other. So I was trying to explain to him what I was going to do. The only thing I could clearly hear was, I can't breathe. I can't breathe. And I said to him, I know. I am here to help you. And he was trying to say something, couldn't hear him. Eventually, he just nodded his head and reached out his hand. The 2 of us held hands briefly, held on tightly. And then my colleague and I injected into his drip, anesthetized him, and we intubated him. And that was the last time he spoke. So we had to put on another layer of gown, another layer of gloves to perform all the lines and everything. And after more than an hour of working hard, an hour and a half actually, of putting up lines and making sure that he was safe, his ventilator was set, we left. And when we came out of ICU, having taken off all the PPE that we had, my colleague said to me, did you realize that that is so-and-so? And he gave me a name. And that name was somebody that I've worked with. We all had worked with in that hospital for over 20 years in that hospital. He was actually a colleague. And in that PPE and in that mask and with swollen eyes, I didn't recognize him. And I wished that I could walk back in and say, hi, how are you doing? How are you feeling? But that he was intubated. He couldn't talk. He was paralyzed. So that's 4 days later, he passed away. And the morning, he passed away in the middle of the night. That morning, when people knew about his death, the whole hospital, I think we have everyone that was on duty lined the corridors outside the ICU. And as they brought him out, there was dead silence. There was no sound. Usually there is singing, even if it's mournful singing, there was absolute silence. Everyone, I think, just stunned. I don't know what people were feeling, but I could barely stand. It was a very shocking experience. Yeah. So that was the first healthcare worker that we lost in that hospital. Yeah.
Yeah. And thank you so much, Caroline, for sharing that. You know, it's really heavy, and just hearing that personal side of it, I think, makes it so much more real, and experiencing that. And did you find that after that, I mean, how did the team cope, especially with losing more colleagues or more colleagues testing? Was there any kind of residual effect days or weeks afterwards?
Yes. So that happened to be one of our very first few COVID positive patient in our hospital. It was very early on in the pandemic in Johannesburg. It was beginning of the surge. So I think that was the time when we hadn't experienced too many. I think it might have even been the first death. And we haven't experienced the surge that they had in Western Cape as yet. So I think the death, not only of a colleague, but of a patient, actually suddenly raised awareness in everyone of our own mortality. And from that day on, the hospital was very, very somber. You don't hear anybody laughing, greeting each other, and people were putting on their PPE a lot more seriously. They were social distancing a lot more seriously. So there is definitely a change in how people view, and everything was just so somber, actually. And when we lost our second one, I think that was much more shocking. I think when everybody took extra care of protecting themselves and making sure that by the time we lost our second colleague, it was 2 months down the line. So everybody had gone through looking after very, very sick patients. There have been lots of deaths. We have massive numbers in our ICU. So we are used to working in difficult conditions. We're used to having patients die, and we're used to having colleagues get sick, actually. But when we lost our second healthcare worker, I think there was massive collapse. People were openly expressing their grief, even before the healthcare worker died. Actually, it was even during the resuscitation process. I think a lot of colleagues, nursing staff in the ICU, weren't able to deal with it. They couldn't even go into that room. It was very, very difficult.
It is, and I think it gets closer to home when it's people you've worked with and it's people within, the front lines with you. I think it makes it even more heavier. And just reading in the comments, I think everyone is also sharing and really appreciating you opening up and sharing that part. And it's those kinds of things that we don't get to talk enough about and to share, because we're going on to the next. And I think also, Caroline, you've been deeply involved in the Healthcare Workers Care Network, and as well as within the own wellness within SASSA and dealing with your colleagues. And you've been fielding some of the online requests that we've been getting and hearing from frontline healthcare workers. Are there any particular main concerns around COVID-19 that has caused the most anxiety or stress? Any trends that you've picked up?
Yes, the majority, especially up till probably about August. So until the end of July, the vast majority of the anxiety was about personal safety. Now, after all, safety is one of the fundamental human needs alongside shelter and food. So there was major distress about safety, whether I don't want to get it, how do I protect myself, how do I protect my family, how do I prevent spreading, I'm too scared to go to work, I've got comorbidities, how can they tell me to go to work, you know, that type of question. And then there came people that worried about, because they're getting tested and they're now very scared of the results, and they call in to almost like get reassurance that their results going to come back negative, or if it's positive, they're going to be all right, just the reassurance. And then came, I tested positive, what do I do? And that's very practical questions that they're anxious about. How do I protect myself? How do I isolate? I live in a small home. How do I protect my family? I'm feeling so sick. How am I going to get back to work? How long must I stay in isolation? Do I have to go back to work? I'm still short of breath. That type of questions. And then now in August, we're starting to see less and less of that type of questions, and more, I'm feeling a little bit more distressed. I need to speak to someone. Yeah.
Absolutely. And I think, you know, from again, your experience, do you think that healthcare workers are focusing on their mental health right now and getting help? And if not, why?
The answer is no, because we are still in the pandemic. I think at the moment, most healthcare workers are too tired, they're too busy, and they're too anxious to actually worry about their mental health. Remember, you only do introspection, and you only think about what you are feeling when you actually have time to sit down and actually look inwards. At the moment, everybody's running on adrenaline. They're just barely coping. They're getting to work. They are starting to familiarize themselves, spending a lot of time. I know my colleagues, we're spending just about every day on webinars, sometimes 2-3 webinars a day, just to learn all the new developments, you know, fielding questions on vaccines, fielding questions on treatment, nurses as well on all sorts of webinars. They are also working long hours, and also a lot of the healthcare workers are working out of their comfort zone. So there's a lot of new things to learn, new equipment to learn how to use, new information, new procedures that they need to learn how to do. And so nobody's got time to actually sit down and take a breath and say, how am I feeling inside? And I think that's the reason why they are not seeking mental health yet, unless people that have prior experience with seeking mental health help, they may sort of think about it. But most people are just coping, really, too tired to even think what they're feeling.
It's so true. It's just kind of getting one step in front of the other. And this is why having these conversations and starting these talks is so important. And Dr. Caroline Lee, I know we could go on the whole evening, and I'm really glad that we can definitely host other webinars on topics. And I just really wanted to say, from me and everyone else that's been commenting, thank you so much for sharing and opening and bringing the human connection to it. You know, in a time where we're all talking about physical distancing, you know, it's so important that we socially connect still. And just from the comments, everyone hugely respected and appreciated you opening up. So from me, thank you very, very much. And in the Q&A, I'm sure we'll have some more questions, but I know that you're always able to help and assist. So thank you very much for your time.
Thank you for having me.
Fantastic. Now I'm going to hand over to Dr. Ella Manga, who's going to just take us through, and probably at the perfect time, as we've, you know, really tackling this heavy topic, just to introduce Dr. Manga. She's an integrated medical doctor committed to bringing the heart back into the art of medicine. With her background in Western medicine and the study of wisdom traditions, has informed her unique approach to health and well-being. I had the pleasure a couple of weeks ago of attending her Breathworks workshop, and it was amazing. I do urge everyone, I'll share the link to the webinar, as well as her shorter videos about the power of breathing and some simple techniques, has been really amazing. And we even practice it within SADAG on a daily basis. So over to you, Dr. Ella. Thanks for your time as you take us through probably the perfect time, a breathing technique exercise.
Thank you so much, Cassie. Good evening, everyone. It's really wonderful to be with you all this evening. So perhaps we could just use this opportunity to land back in our bodies and to hand over this process of integrating everything that we've heard, that we've felt, that has been triggered for us this evening with the breath. So just use this opportunity now to make yourself comfortable wherever you are. Just sitting back in your chair, or perhaps making yourself more comfortable, changing your position, moving to a couch, perhaps even lying down if that feels comfortable for you. And taking an expanded inhale now. With the exhale, just allow yourself to drop back into your body. Let the next exhale support a surrendering of the mind to the heart. Of the mind to the breath. Another soft sigh now. Just allows a feeling of safety in your body, in your being. Allow the next soft exhale to bring a softness to the back of the neck and the shoulders. Relaxing in the natural rhythm of your breath. Just enjoying the experience of the inhale and exhale. Not trying to breathe in any particular way. Simply observing, simply feeling, watching, and appreciating the gift of life, the gift of breath. And just give yourself a moment to feel into your body. Perhaps just getting a sense of where your body has been holding your feelings. Just appreciating what your body has been holding for you. And expanding your inhale, feeling that you are kind of breathing into that space, making space to hold that feeling. And allow the exhale to soften your body even more, to soften that space even more. Just keep feeling that you're breathing into that space. Just handing the process of integration to the mind, to the breath. Just letting the mind go, handing it over to the breath. Nothing to do, nothing to figure out. Just let the breath support the processing. Just in this moment, feeling safe in your body. Allowing the feelings to rise up. Embracing them with an expanded inhale. And releasing with a soft exhale. imagining that the breath is rising from deep within your being and expanding outwards. Every breath is soothing. It's just using this time to rest and restore. And now, just bringing your breath back to its normal rhythm. Once again, noticing what's being triggered for you. A feeling of softness, perhaps. And when you're ready, just give yourself a stretch. Acknowledging all that you do, all that you give to others. And acknowledging this time, even a few breaths, to give back to you. Just expanding your breath as you bring yourself back up to the space, into the room, stretching and opening your eyes if they're closed. Thank you for sharing this space and this time with me this evening. And I wish you a restful evening.
Thank you so much, Dr. Ella. I think it was a perfect time to just take a deep breath, refocus, and also just allow us that space to carry all of that heaviness and just have a deep breath and just let it go. I think it's really important that we ourselves look after our own mental health and give ourselves our own chance just to take a deep breath and reconnect so that we're able to take the next steps. I'd just like to welcome my colleague now, Dr. Antoinette Merge, just to help us with some of the closing and on the Q&A. If I could just welcome her to come forward. Fantastic.
Thanks, Cassie. Thank you so much. And thank you so much, Ella. That was really, really great. While we were planning this webinar, we were kind of, if you think back to our first webinar, we were talking about stress regulation. And we were talking about hyperarousal and hyperarousal and how to regulate yourself. And we're very aware that the topics presented tonight are quite difficult topics. And that's why we asked Ella to bring some of her magic in terms of the breath works, just to kind of regulate us all as we end off this webinar. So, Cassie, can you see any of the questions, if there are any? If you can post any, if there are some coming through. I see some people are yawning, so yes, it was aimed to help people sleep now.
Fantastic. I'm just actually trying to get the screen share and get our other experts on. If I can start with some of the questions that we've received on the chat, and thank you everyone for, you know, just coming forward and sharing so much. It really helps us to bring all the information going forward. So we've had a question tonight. Wants to know about returning to work sick leave for a healthcare worker with comorbidities and still have to work with COVID positive patients. Is there any guidelines or tips that we can take forward? Antoinette, can I pose that to you, or if anyone else of our panel would like to take that on?
Maybe to Caroline.
Caroline, can I come to you?
Yes, you can. Okay, so at the moment, there are very few cases of reinfection with COVID. There seems to be some numbers popping up where there may be suspect reinfection after having developed COVID or tested positive for COVID. It's not confirmed as yet. Look, there are 22 million people in the world that tested positive for COVID, and the number that we are talking about reinfections is very low. It's probably not more than a few hundred. So we're not sure if those are actually reinfections, because it requires work on the RNA and to finding out that it's a different RNA and not the original one, because if it was the original one that you were infected with, it probably could be like malaria, where it flares up, you never cleared it in the first place. So my suggestion to healthcare workers is that even if you had tested positive, you should take care as if you haven't from before, and not worry about getting the reinfection. The numbers are too low to worry. So just take great care, as you would anyway with your PPE.
Fantastic.
There's nothing to fear.
I think it's always nice to hear again from the front line, again, when we're not so sure. So thank you for sharing that, Caroline. I have another question here, and perhaps this could be for Dr. Joanna Taylor. Can moral injury be the start of healthcare workers rethinking how we provide care to our patients, and how much freedom healthcare workers should have to care for their patients, rather than be guided by strict organizational rules? Would you like to comment on that? Dr. Taylor, I don't know if you're...
Thanks, sorry, I'm trying to unmute. I'm a little bit confused by the question. Certainly, I think that moral injury, as with so much about this pandemic, provides us with an opportunity to rethink how we do things. And with regard to training, with regard to best practice, with regard to how we support each other. I'm not sure that limiting the freedom of doctors to make, or of healthcare workers to make decisions would be the answer. But if you're talking about improved support by improving the strength of protocols and the strength of evidence available to support decisions, etc., then perhaps that would be helpful. But I'm not certain that I've understood the question correctly. Perhaps you can expand if I haven't understood it that well.